Case-Based Review course. Welcome to the Case-Based Review of Musculoskeletal Radiology, session MSCS 52. I'm Dr. Stacy Smith, the director for the musculoskeletal section, and I would like to thank at this time our track chair, Dr. Ricardo Restrepo. Over the next hour, you will hear from 4 excellent speakers regarding the following topics: soft tissue, infectious and inflammatory MSK, MSK intervention, and MSK imaging of pitfalls in the elite athlete. I'd like to start off the session with our first talk. Again, my name is Dr. Stacy Smith from Brigham and Women's Hospital, Harvard Medical School in Boston. The next 12 minutes will be spent discussing soft tissue lesions, in particular subcutaneous soft tissue lesions. I have no disclosures related to this presentation. Our learning objectives are to review some optimal imaging techniques and to learn some important clinical aspects and characteristic imaging features of subcutaneous soft tissue masses, in particular to discuss key imaging findings which allow differentiation between each of the differential diagnostic subtypes. Today's talk will be centered around this key case, which is a 49-year-old female who presented with a painful soft tissue mass in her foot. She had no history of trauma and she had no history of malignancy. We are presented with the T1 and T2 weighted short axis MR images, which demonstrate a well-defined lobular lesion centered in the subcutaneous tissues, which is isointense to muscle on T1 and heterogeneously increased signal on our T2 fat-saturated sequences. Note that there is subtle remodeling of the dorsal cortex of the 5th metatarsal, and there's also a thin vessel extending dorsal medially from the base of the lesion. When we are presented with a soft tissue mass in the lower extremity that's well defined and localized, we have quite a long list of items in our differential diagnosis, which I've listed on the right-hand side, those including neurogenic lesion, nodular fasciitis, ganglion, giant cell tendon sheath, epithelial inclusion cyst, vascular lesions, rheumatoid nodules or fibromas, as well as myxomas or synovial sarcomas. So how do we differentiate between these lesions? Our next step is to provide contrast. This is very useful in that we can eliminate immediately 3 of these structures, in that ganglions, epithelial inclusion cysts, and more commonly myxomas demonstrate peripheral enhancement rather than homogeneous enhancement post-contrast. We are presented with the T1 fat-saturated pre- and post-contrast images demonstrating increased signal intensity post-contrast with diffuse enhancement of this lesion. There is a tiny little vascular enhancement immediately medial to the base of the lesion at the dorsal aspect of the 5th metatarsal. Given the appearance, our first question is, what is not a differential diagnosis for this particular lesion? Is it neurogenic? Is it number 2, giant cell tumor tendon sheath? Is it number 3, ganglion? Number 4, synovial sarcoma? Or number 5, vascular lesion? Well, given the appearance that we have given, in that it is a thin, peripherally enhancing structure, a ganglion can be excluded as it does not look like our test case. Similarly, myxomas may have a peripheral enhancement pattern due to the mucinous material within these lesions that may look like a thickened ganglion. Myxomas are typically more intramuscular than subcutaneous, so myxoma is likely excluded. Ultrasound can be very useful in these cases to help differentiate a solid from cystic lesion, giving the true hypoechoic appearance, thin capsulated wall, and acoustic enhancement through transmission, which we see on this example here. Important. I've also included epidermal inclusion cyst in this particular entity that we are excluding, as it also has a thin peripheral enhancement post-contrast. Our next lesion for comparison provides this T2 fat-saturated image. It is a heterogeneously increased signal, well-defined case dorsal to the second and third metatarsals. On sagittal T1 fat-sat post-contrast imaging, we are provided with this heterogeneous increased signal intensity lesion with a specific sign. And our next question is, what is this sign? Is it 1, a split fat sign? Is it 2, a target sign? Is it 3, the triple sign? Or 4, a bag of worms sign? And in this case, this is the split fat sign, characteristically showing displacement of fat in an intermuscular location at the entering and exiting nerve in a neurogenic lesion, most commonly neurofibroma, but can be seen in schwannomas. The target sign is classically identified as a central area of hypointensity with peripheral hyperintensity on T2 or fluid-sensitive sequences. Post-contrast, there is typically central enhancement with peripheral hypointensity. This is due to central fibrocollagenous core with surrounding myxomatous tissue, which accounts for this imaging pattern. The triple sign refers to 3 specific types of signal intensity due to multiple tissue types. In this case, there's hemorrhage, there's a phlebolith, there is little fat, and there's fibrous tissue in synovium, and this is classically seen in synovial sarcoma. The bag of worms is seen in hemangiomas and plexiform neurofibromas due to vascular tubular structures in the hemangioma and tubular-like structures in the plexiform neurofibroma. In this case, this is a neurofibroma or schwannoma. In this case, it was actually pathologically diagnosed as schwannoma with the split fat sign and nerve. Our next case demonstrates isointense lobulated lesion dorsal to the metatarsal head and neck. But in this case, we can see a internal, linear, persistent, low signal structure, which is the extensor tendon. This helps to clarify the location and the entity known as giant cell tumor of tendon sheath. These can have mild heterogeneous enhancement patterns. They typically remain lower signal intensity, and they do tend to be surrounding and arising from tendons. Included in this discussion also is fibroma. These tend to be lobular, well-defined, isointense to slightly lower isointensity to muscle. They demonstrate linear low signal bands on their fluid sensitive sequences as seen in this structure within the foot. Rheumatoid nodules or fibromatosis can be identified as isointense to muscle surrounding fascial planes with linear areas of low signal fibrosis. Synovial sarcoma is also included in our differential diagnosis. The image on your left, T2 fat saturated sequence, demonstrates increased signal lobular soft tissue mass within the deep soft tissues in the muscle surrounding and extending around the tendons, which are seen as low signal structures. This is heterogeneous in appearance, and post-gadolinium can demonstrate multifocal heterogeneous appearance and increased signal, as we can see on the sagittal T1 fat saturated image of this particular case. Of note, synovial sarcomas demonstrate 30% calcification. The triple sign are seen in younger patients and can be a great mimicker of both benign and malignant lesions. Finally, we're going to talk about vascular lesions. Remember, our patient is this painful soft tissue mass. It demonstrates diffuse homogeneous increased signal enhancement pattern and heterogeneity on our T2 fat saturated sequence. The most common lesion is a hemangioma, which is the most frequent benign foot tumor of vascular origin. It has 3 types, which are capillary, venous, and arteriovenous combination. These typically are characterized by internal fat and flebulous and tortuous vessels. The lesion on your left shows the characteristic fat signal intensity on the T1 weighted image on the top, and the characteristic increased signal tortuous vessels on the T2 fat saturated sequence, with focal areas of flow voids and focal areas of low signal flebulous in this dorsal mass confirmed as a hemangioma. The other lesion in the vascular category, which is quite rare but warrants discussion, is angioleiomyoma. This is a benign smooth muscle tumor that comes from the tunica media veins. It is typically in the lower leg, arising from the dermis or subcutaneous fat. It typically presents as a firm, small nodule with pain in approximately 60% of cases. It is more commonly seen in middle-aged females more than males. I've got our test case on the left, and on the right I have presented images from Yu et al.'s article in AJR 2009 demonstrating another example of angioleiomyoma. We will see here at the white arrow on a T1A weighted image, oval well-defined iso-intense lesion to muscle with increased diffuse signal intensity on the T2 weighted image with a small entering vessel. As we look at our case, we can see that small entering vessel, which corresponds to small area of enhancement on the post-contrast image below it. This lesion was biopsied and revealed the following pathology. The pathology on this scanning magnification view shows circumscribed tumor nodule in the subcutaneous tissue comprised of densely packed interlacing bundles of smooth muscle which surrounds small compressed vascular channels. The final diagnosis of this lesion was an angioleiomyoma. While this is a rare lesion, it is important to note that it can occur within the lower extremities and that it can mimic other entities more commonly seen within the foot. In conclusion, we have looked at several key points with relation to soft tissue masses within the subcutaneous tissues of the foot. In particular, we have looked at both benign and malignant lesions. Remember that the lipoma is probably the most common benign lesion within the foot, but certainly did not have the characteristic appearance in this case. Remember that synovial sarcomas are seen in about 10% of all soft tissue tumors, and to include that as a possibility in a younger patient. Pleomorphic undifferentiated sarcoma is also possible within the lower extremity. I'd like to thank you all for your attention. Below is a list of references. And at this time, I would like to turn the time over to Dr. Hugh Willett from the University of British Columbia, Vancouver, British Columbia, who will be presenting the topic Infectious and Inflammatory Musculoskeletal Imaging. Dr. Willett.
Hi, I'm Hugues Willett, and I'll be speaking about infectious and inflammatory MSK imaging. I have nothing to disclose. The first case is an 8-year-old patient with knee pain. It's a frontal view of the knee demonstrating osteolytic lesion at the proximal tibia extending into the epiphysis. Now, when we analyze the lesion a bit further, we see that the lesion is U-shaped, which is odd for neoplasm, which usually grow in a sphere. There is also a well-defined margin with sclerosis that fades out. This is typical of irritative margins, usually caused by inflammatory process or infection. This is a Brody's abscess, and the shape is by the infection burrowing through bone. Here is an example of Brody's abscess, more spherical this time, but also with reactive margins. Compare that to giant cell tumors, which have a more inert margin, well-defined without sclerosis fading out. And also, compare this with an intraosseous ganglion that has a thin white line as a margin, also not fading out. Another type of margin that we sometimes see is an involuting margin, such as NOF, Here we have an example of this with sclerosis, and some sclerosis fading in at the proximal aspect of the lesion. Eventually, the lesion involutes and becomes mineralized, such as in this case. Osteomyelitis can look more aggressive than having a focal lesion, can be moth-eaten, such as in this case. So, bone infection and inflammation, look for reactive sclerosis that fades out. The second case is a case of a 17-year-old with severe knee pain. There's a lesion at the epiphysis at the lateral tibial plateau with extensive bone marrow edema visualized on MRI. Note that the edema fades out, and this is typical of irritative lesions, such as in this case. This is an example of chondroblastoma. On CT in the same patient, there is sclerosis fading out, also indicative that the lesion is irritative. These lesions can be ablated thermally. Another case in a 17-year-old with ankle pain with a lesion at the distal tibia with irritative margins with sclerosis fading out. And this was an osteoblastoma. This case in a different patient with a small lucency at the proximal femur in keeping with a nidus, and there's diffuse sclerosis adjacent to it fading out, irritative margins. This is an osteoid osteoma. Another example of osteoid osteoma, the proximal tibia, with a lesion at the cortex this time, and with diffuse edema visualized on MRI. So, bone infection and inflammation. Look for reactive sclerosis fading out on plain films and CT scan. Also look for reactive edema fading out on MRI. Remember that some tumors cause inflammatory reaction, such as chondroblastoma, osteoid osteoma, and osteoblastoma. Now the third case is a middle-aged man with shoulder pain. If we look at the radiograph a little bit more closely, we can see that there's subchondral erosion at the distal clavicle, but also at the acromion, which makes this a joint problem. In addition, there's some destruction of the distal clavicle in the bone and some soft tissue swelling. On MRI, there is extensive collection adjacent to the AC joint, involving the AC joint, with destruction of the joint and enhancement. This is an example of osteomyelitis with septic arthritis. Companion case with distal clavicular osteolysis and rheumatoid arthritis, with this case showing a well-corticated distal clavicle and distal clavicular osteolysis and hyperparathyroidism. Septic arthritis on MRI, we see synovial proliferation and thickening with enhancement. We see joint effusions and osseous edema with erosions. Tuberculous osteoarthritis, the classic triad is Femester's triad with juxta-articular osteoporosis, osseous erosions, and gradual joint space narrowing. Now, infection typically is monoarticular. Other arthritides are more likely to be involve multiple joints, such as in this case in psoriasis, where we have pencil and cup deformities and erosions in multiple joints without symmetry. In the case of rheumatoid arthritis, we have symmetric periarticular soft tissue swelling at first, with osteopenia and uniform curves. And then later on, we have prominent erosions with cartilage loss and malalignment And eventually, we have ankylosis, such as in this case in JIA, with fusion of the carpal bones. MRI is great at seeing early erosions, but also can see synovial hypertrophy very well with enhancement and bone marrow edema, as well as peritendinous disease such as tenosynovitis. Neuropathic joints can cause inflammatory changes around the joints, and typically are seen as destruction and dislocation of joints with distension, increased density, and debris. This entity is related to hardware failure. There's a medial compartmental replacement with a fractured tibial tray, and the effusion within the knee is dense. This is an example of metallosis. In addition, obviously, soft tissue inflammation can occur from sports injury. This is a partial tear of common flexor origin in a professional baseball player, as an example. Hi, Okay, case 3 is a middle-aged woman with neck pain. And if we look at the radiograph more closely, we can see at C4, C5, the end plates are ill-defined. There's also soft tissue swelling. On CT scan, there's irregularity of the end plate. That's in keeping with discitis, osteomyelitis, proven by biopsy. Another example in the thoracic spine, same appearance, destruction of the end plates. Then when we look at the MRI, there's fluid within the disc with edema at adjacent vertebral bodies. Also in the post-operative state, can get infections, and in this case, the prevertebral soft tissues are swollen. On CT, we can see a collection in keeping with an abscess. So typically, infection is usually involving a single joint, more likely, whereas in other arthritis, multiple joints are involved. This is an example in JIA of fusion of facet joints proximally, and in psoriasis, diffuse fusion of facet joints. Ankylosing spondylitis, we see syndesmophytes diffusely, and in these patients, we always have to look for a chance-type fracture called Anderson lesion. Here, there is a subtle one at the cervical-thoracic junction. Here's a different example in ankylosing spondylitis of a more obvious Anderson lesion, which was fixed. So, septic arthritis and discitis, typically monoarticular or one disc. Look for erosions at both sides of the joint or disc, and soft tissue swelling and adjacent abscess. Case number 4, 74-year-old male, presents at the emergency department with a 24-hour history of pain and swelling of the second toe. Query, osteomyelitis. So here we see destruction of the second distal interphalangeal joint with marked soft tissue swelling. However, in a CT scan, we can clearly see a green area there, which represents urate. The appearance is in keeping with gout. Here's a different example of a gout. We have an osteochondral defect at the dome of talus with a small area of mineralization within the joint. On dual energy analysis, we can see that this is urate in keeping with gout. And another example of gout in the spine, this time with a small area of mineralization at the right facet joint capsule. Not visible on MRI, very difficult. However, on dual energy analysis, we can see a small area of urate at this site. So if there's any chance that the patient might have gout, think of dual energy CT. It's a great tool to diagnose gout. So in summary, we've looked at several cases of infection in different locations. We've looked at tumors that cause inflammation, such as osteoid osteoma, osteoblastoma, and chondroblastoma, and we've looked at classic appearance of several arthritides. That's it for me. Now, Glenn Gaviola is going to be next, speaking about MSK intervention. Thank you.
Good afternoon, everybody. My name is Glenn Gaviola. I am a musculoskeletal radiologist at Brigham Women's Hospital, and this afternoon we'll be going through a case-based review of musculoskeletal radiology with interventional cases. I have no financial disclosures. So over the next 10 minutes or so, our learning objectives will be to use a image-rich case-based presentation to review some of the more common musculoskeletal image-guided interventions with a focus on arthrography and biopsy. We'll recognize some of the common pitfalls associated with these interventions and understand the evolving controversies associated with these interventions. So we'll go through a few cases. So this first case is a patient with shoulder pain. So in the image to your right, we'll answer this question, true or false. Fluoroscopic guided glenohumeral shoulder arthrogram shows a full thickness rotator cuff tendon tear. So in order for us to analyze this, let's go and quick review about fluoroscopic guided shoulder arthrography, the glenohumeral joint. So ideally, when we do our injection, we'd like to put the needle into the glenohumeral joint, inject a little bit of contrast, and confirm that we're intra-articular. And one of the most specific signs that you are intra-articular is this sliver of contrast that outlines the glenohumeral joint, in which case here we see the overlying humeral head cartilage, confirming that it is intra-articular. After injection of approximately 10 to 12 mLs of contrast, we'll see that the outline of the joint as we see here, in which case one of the most important things to note in a normal arthrogram is the absence of intra-articular contrast within the subacromial region, as we see here. And as we outline the joint, you'll be able to see that we have nice distension of the axillary pouch and also of the subscapularis recess below the coracoid here. And again, we'll see that sliver of glenohumeral contrast outlining the humeral head. So in our index case that we see, we do recognize that we are intra-articular, confirmed by the glenohumeral crescent, but compared to our normal arthrogram, we see that we have contrast in the subacromial subdeltoid region. And this is indicative of a full thickness rotator cuff tear. In addition, we also see contrast within where we would expect the tendon fibers to be, and this is in keeping with a full thickness rotator cuff tendon tear with delamination into the torn tendon fibers. This is best seen on our subsequent MR arthrogram on our coronal T1 weighted sequences demonstrating that region of delamination of the tendon fibers. So back to our original case. Fluoroscopic guided glenohumeral shoulder arthrogram shows a full thickness rotator cuff tendon tear. And of course, the answer is true based on our evaluation. So moving on to our next case, another patient with shoulder pain. And to make it easy, the question stem is the same. With this particular case, fluoroscopic guided glenohumeral shoulder arthrogram shows a full thickness rotator cuff tendon tear. True or false? So if we go back to our basic principles of what a normal arthrogram should look like, again, in the initial injection of contrast, we should see the glenohumeral crescent outlining the intra-articular nature of the contrast, and normally the absence of subacromial subdeltoid bursal fluid, indicating that all of the contrast is confined within the glenohumeral joint. And in our case that we're looking here, we recognize that we see contrast within subacromial subdeltoid bursa. However, if we look back on our basic principles again, you'll notice that we're not really seeing a sliver of contrast that we would expect outlining the glenohumeral crescent or the contrast. And so the question remains, is this really articular? On the subsequent MR arthrogram, T1 weighted FATSAT, we recognize that there is contrast within the bursa, and it actually does show a bursal-sided tear of the supraspinatus. However, when we look at the contrast that we would expect to see in the joint, we don't see any. And here you can see that the humeral head cartilage is closely opposed to the glenoid cartilage without intervening contrast. Thus, the contrast is in the subacromial cell deltoid bursa, but is not in the glenohumeral joint. Therefore, in thinking about this case, fluoroscopic guided glenohumeral shoulder arthrogram shows a full thickness rotator cuff tendon tear. The answer is false because this was not a glenohumeral shoulder arthrogram, as the contrast was not in the joint, but instead outlined throughout the entire bursa. On these sagittal views, we see how the subacromial subdeltoid bursa is actually in communication with the subcoracoid bursa. And thus, this was an incidental or inadvertent subcoracoid bursal injection during attempted glenohumeral arthrogram from an anterior approach. And this is a pitfall in shoulder arthrography. So compared to our normal, it's important to recognize that we need to look for that glenohumeral crescent at first injection to confirm that needle tip is intra-articular. And if we don't see that initial contrast, that your needle may actually be extra-articular and not within the joint itself. So an important pitfall to recognize. All right, moving on to our next case. This is a middle-aged male with history of right groin pain and a remote history of trauma who presented for an MRI, which demonstrated this heterogeneous contrast-enhancing mass in the right groin region. Subsequently, the patient was referred for a biopsy of this, given the concern for an underlying soft tissue neoplasm. In the images we see in the bottom, the scout CT images prior to biopsy. So based on the MRI results, the patient was referred for the biopsy. Which of the following is the next best step in management? Should we proceed with the biopsy as planned? Should we perform a lavage instead of biopsy? Should we call the referring physician to discuss the necessity of biopsy? Or should we perform a cryoablation in addition to the biopsy? Well, in this particular case, a CT scan shows that the soft tissue mass actually has a thick rim of peripheral calcification that appears well differentiated with the cortex and the medullary space. And thus, this is pretty diagnostic of myositis ossificans. Thus, it's important to call the referring physician to discuss the necessity of the biopsy because of the fact that under histological appearance, biopsy of myositis ossificans can actually be quite worrisome. So myositis ossificans is heterotopic ossifications associated with trauma, often presenting with pain and a soft tissue mass. Its imaging appearance early can look like an aggressive soft tissue mass with a bunch of edema on the MRI. And calcification can take 2 to 4 weeks with this peripheral osteoid and central trabeculation, and only later can it be a well-defined osseous mass. Again, this is cladic scalea, do not touch lesion, and I think the importance here is recognizing that we need to maximize our diagnostic imaging before intervention is planned. So again, take-home messages. Myositis ossificans can look aggressive on MRI, and we should really maximize our diagnostic imaging before we do the biopsy. So contrast that with another middle-aged male who presented with recent swelling and numbness to his lower leg. So again, MRI examination demonstrated a aggressive appearing soft tissue mass with extensive edema within the posterior compartment of the right thigh. So what diagnostic imaging test would be the next best step in further evaluation of this lesion? Should we do radiographs, bone scans, a PET CT, or none of the above? Should we go direct to biopsy? So comparing our lessons that we learned from before, we need to maximize the diagnostic value. And radiographs are often the easiest next best step to do to look for the mineralization that we would expect to see with myositis ossificans. Radiographs were performed and demonstrated no mineralization associated with this soft tissue mass. Thus, myositis ossificans was thought to be less likely, and the patient was further referred for biopsy under ultrasound guidance. Biopsy revealed the pathology to be cellular myofibroblastic proliferation with ossification, raising the possibility of myositis ossificans. And in fact, there was no evidence of malignancy in the biopsy specimen. However, clinical and radiologic correlation was recommended. Well, given the absence of mineralization and still the concern for myositis ossificans, the patient underwent a CT scan examination 2 weeks later, which demonstrated the peripheral mineralization associated with these. So the take-home message here is that the calcification can often be delayed and take 2 to 4 weeks before we identify that. And CT has better sensitivity than X-rays oftentimes for this early mineralization. So the management can be of these lesions can follow surgical resection after maturation, and oftentimes these can be followed with serial imaging. It's important to note that malignant transformation is rare. So our last case is our 63-year-old male, healthy, who presented with progressive left hip pain. So radiographs demonstrated an aggressive mineralized lesion in the left femoral intertrochanteric region, concerning for malignancy. A PET CT scan examination revealed FDG avidity with associated destructive soft tissue mass, and a CT-guided biopsy was performed at an outside hospital through the anterior approach through the rectus femoris. So the approach utilized for biopsy of this femoral neck lesion is consistent with published anatomically based guidelines for limb-sparing surgery. True or false? And we'll recognize here that the rectus femoris muscle is actually outside of the limb-sparing surgical treatment field. So with limb-sparing surgery, this is the advent of these limb-sparing surgical techniques for treatment of primary musculosarcomas helps spare amputations in many patients and limits the loss of function. And it's important to recognize the compartmental anatomy of the musculoskeletal system planned along with the surgical excision route to have the optimal sampling to avoid contamination of tissues. Otherwise, the patient may need to undergo additional resection, radiation therapy, or amputations. And it's important to consult with your local orthopedic oncologist on the best surgical approach prior to biopsy. Local recurrence has been reported from tumor seeding across biopsy tracts in 16-gauge needles, especially when they're not resected, though this has not been quantified systematically. And there's a 5-fold increase in recurrence rates with definitive surgery when biopsy scar was not removed at open biopsy. However, it's noted that there's no significant risks with tracts from fine needle aspirations, such as 22 to 25-gauge needles. And I'll refer you to this paper in Radiographics from 2007 demonstrating anatomically based guidelines. So following the compartmental anatomy approach, a intertrochanteric biopsy should have been performed from a lateral approach rather than anterior through the rectus femoris here. However, this is an evolving controversy that is current. Such seeding occurs. It's never been documented that crossing anatomical compartments leads to less favorable long-term outcomes, and that advances in coaxial biopsy systems and neoadjuvant therapy have significantly reduced the need for uncommon tract seeding with percutaneous sampling. Although considering that we need more prospective multi-center studies, as has been discussed and reported by the UCLA group. So our take-home points for today. Recognize that subcoracoid bursal injection could mimic a full-thickness rotator cuff tendon tear, particularly with an anterior approach. Consider myositis ossificans in your differential with soft tissue mass, especially if it's aggressive in appearance, especially prior to biopsy. And make sure you discuss biopsy approaches with your orthopedic oncologist to see if they agree with compartmental anatomy approaches. So hopefully over the course of this learning session, we reviewed some of the common imaging interventions in musculoskeletal with arthrography and biopsy. We recognize some common pitfalls associated with these interventions, and we've understood the evolving controversies associated with the interventions, in particular compartmental anatomy approaches. Thank you for your attention and participations, and happy to take questions. And with that, I'd like to introduce our next speaker, Dr. Clarissa Canella, speaking on musculoskeletal imaging of pitfalls in the elite athlete. Thank you very much.
Good morning. First, I would like to thank the Scientific Committee for invitation. It's a great opportunity to be here. We're going to show some images in this presentation from the Olympic Games of 2016, and for that we have the official authorization of the International Olympic Committee. I also would like to thank my colleagues from the musculoskeletal department where I work. I'm going to show 3 pitfalls according to the most common lesions on the Olympic Games of 2016, and we can see here that the first pitfall, we are going to talk about bone injuries, the second muscle injuries, and the third meniscal tears. So let's see this case. It's a boy, 20 years old, with pain in his right leg after a soccer match, and this MRI was for evaluation of stress fracture, and we can see here that we have this bone marrow edema with periosteal reaction. Note that we have this expansive pattern of the tibial diaphysis, and in that case we need to think about osteosteoma and bloody abscess. On dynamic contrast enhancement MRI, we could see this early and important enhancement of the posterior aspect of the lesion with a curve type 4, that a washout curve suggesting a high vascularized lesion. And in that case, we had a case of osteoidosteoma. We can also use chemical shift MRI for the evaluation of osteoidosteoma, as we can see here the persistence of signal intensity of the needles on outphase imaging and the significant reduction of signal intensity of the surrounding edema, suggesting bone marrow inflammatory infiltration. Let's compare with this case, a female, 22 years old, pain in the left leg, MRI for evaluation of stress fracture, and here we can see this cortical lesion with a periosteal reaction. We can note this cortical rupture with extension to the surrounding subtissue. On dynamic contrast MRI, we could note no significant enhancement of the lesion, with this important enhancement of the surrounding subtissue with a curve type 3, indicating a poor vascularized lesion and making the osteoidosteoma an unlikely diagnosis. In that case, we had a case of bloody abscess after biopsy. We can also use chemical shift MRI for the evaluation of a bloody abscess. Let's see this case, male, 11 years old, with bloody abscess of the proximal tibial diaphysis. Here we have no significant reduction of signal intensity of the surrounding edema on outphase imaging because of this granulation tissue around the abscess that was also described in literature as the penumbra sign. Let's compare with this third case, a 28 years old professional hurdler, pain in the right leg, MRI for evaluation of stress fracture. Here we have multiple areas of bone marrow edema with no visible fracture line. However, on coronal T1 weighted images, we could see here this small fracture line perpendicular to the cortical, suggesting this stress fracture. Related to muscle injuries, let's see this case, 37 years old, pain and muscle weakness in the right leg, MRI for evaluation of a muscle sprain. And here we can see that the small areas of increased signal intensity within the anterior compartment of the leg, associated with these regular areas of fatty degeneration and atrophy. And this pattern is a pattern that we call early mouth-eaten appearance, that is suggestive of muscle denervation. And when we look here in this illustration of the motor unity, we can see that on muscle denervation, each motor unit is affected separately. That's why we have some muscle fibers that could be preserved, and that's why we have this appearance of early mouth-eaten appearance lesion. Let's compare with the second case, May, 26 years old, with this skin lesion and muscle weakness after a self-administration of mineral oil. And on MRI, we could see the symmetrical and bilateral muscle edema. We also performed a whole body MRI of this patient and could note other muscles that were also affected. And on this patient, we could also see this atrophy and fat degeneration of the whole muscle, suggesting an inflammatory myopathy. When we look at our schematic motor unit, we could see here that on inflammatory myopathy, the muscle fibers are affected directly by myocyte-specific antibodies, resulting on this appearance of whole muscle fat degeneration. This case was a case of an Asia syndrome. Male, 22 years old, a professional soccer player with pain in the posterior aspect of the right leg, MRI for evaluation of a muscle sprain. Here we can see there's architectural distortion of the muscle fibers with muscle edema, also with fluid-filled gaps in muscle substance. And we could note here that we have a lesion less than 50% of the cross-sectional area, with architectural distortion less than 5 centimeters of muscle fibers, suggesting a muscle sprain grade 2A according to the new Pollack grading system for muscle sprain. We can also note that we have some fatty degeneration sometimes associated with muscle sprain. However, a post-traumatic fat degeneration is a localized fat degeneration, usually associated with myotendinous junction thickening. Regarding our last beautiful meniscal injuries, so 27 years old, a professional volleyball player with pain in the lateral aspect of the right knee. It was an MRI for evaluation of a LCA lesion and a meniscal tear. And here we can see this linear increased signal intensity of the posterior whole of the lateral meniscus, and this is exactly at the insertion of the meniscofemoral ligament. And what is it? Is it the meniscal tear? Is it the normal anatomy of the meniscofemoral ligament? So here there are a lot of meniscal pitfalls. We are going to talk about a pitfall related to the normal anatomy of the meniscofemoral ligament and the tears in the posterior whole of the lateral meniscus, because this region in the lateral meniscus is present a complex anatomy, and sometimes it's difficult to evaluate these lesions. So here we have the meniscofemoral ligament from the posterior whole of the meniscus to posterior femoral condyle. This ligament assists the posterior cruciate ligament to resist tibiofemoral posterior draw. And this is the normal anatomy of the meniscofemoral ligament distal insertion. We can see that during anterior translation of the tibia, we will have this ligament traction and tear of the posterior whole of the lateral meniscus, with a tendency to progress forward through the meniscal hole, creating this menisco-ligamentous detachment that opens like a zip, and that we call the zip sign. The zip sign is this straight line on the posterior whole of the lateral meniscus that is present in 5 sagittal imagings, 5 consecutive sagittal images lateral to the posterior cruciate ligament imaging, as we can see here. The zip sign presents an excellent inter-observer agreement with a sensitivity of almost 90%. So let's come back to our case. Here we have the posterior cruciate ligament imaging, and we can see that there's a straight line on the posterior whole of the lateral meniscus is present in less than 3 sagittal imaging, so it was only a normal anatomy of the meniscofemoral ligament insertion. So in conclusion, related to bone injuries, always remember the washout curve and the reduction of signal intensity on outphase imaging for osteosteoma, the penumbra sign for bloody abscess, and always look for fracture line perpendicular to the cortical regarding stress fracture. On muscle injuries, the early move-it and appearance of a muscle denervation, the symmetrical bilateral edema, and the whole muscle fat degeneration of inflammatory myopathy, and muscle sprain, architectural distortion, fluid-filled gaps, and the localized fat degeneration. And related to tears of the posterior whole of the lateral meniscus, always remember the zip sign, and be attention with the normal anatomy of the meniscofemoral ligament insertion. Thanks for your attention.